Hi, my name is Dr. Robert Korom. I'm a primary care doctor with Penda Health, and I'm joining you today from Nairobi, Kenya, where I've been working for the last almost 10 years to improve quality of care in primary care. And today I'm going to tell you about how we're using large language models as clinical decision support tools within our large urgent care practice. So I want to start with basically a patient case because that's how we normally start things in medicine. So this is a 32-year-old woman who seeks primary care because she's had 2 days of itchy vaginal discharge. She hasn't had fever, no pain with urination, no new sexual partners over the last 1 year, and her urine analysis is pretty unremarkable. Looks like it might have been, not a very good sample collection, but it doesn't look like a florid UTI. And then what you're seeing in the top right is a handwritten prescription for two antibiotics, that's ciprofloxacin and metronidazole. And this is a really common scenario that we encounter in our market, in our sort of healthcare ecosystem. And when I add up the costs of this visit, for the consultation, the lab testing, the drugs, we get to about $8 of spend, or a little more than 1,000 Kenya shillings. And for the clinicians who are in the audience, you can probably see that this is really a misdiagnosis. And it's a treatment with antibiotics for what is probably actually a yeast infection. And so, not only is this sort of not helping her problem, it's potentially making it worse because the antibiotics disrupt the normal bacteria that are there, and they really make what her actual problem is worse. And this is a common thing that we see, and it's particularly frustrating because this patient may only spend $50 to $60 per year for all of her healthcare. And so to spend almost 20% of that on something that, is at best useless and at worst harmful is really quite problematic. So what I want to really get across is that the quality problem in low and middle income countries is really urgent, and it's at times life threatening. Within Kenya, we have very low adherence to clinical practice guidelines. So only about 40% of care provided at the primary care level in Kenya is in accordance with national guidelines. That comes from the Ministry of Health. Um, the breadth of practice for our clinicians is really enormous. So the main type of staff that provides primary care in Kenya is called the clinical officer. Nurses also provide a lot of primary health care. And, they treat a huge variety of issues. I mean, for me as a primary care doctor trained in internal medicine, I'm fairly broadly trained. But in a typical day, one of our clinicians is, vaccinating babies and taking care of moms who are pregnant and treating sick children and, treating trauma, motorbike accidents, and people who need stitches, taking care of older folks who have hypertension and diabetes. So the range of conditions that people see during the day is really truly remarkable. And it's hard to keep all of that in your head. So I think that's really an issue in our ecosystem. And then we also have a over reliance on pattern matching. So clinicians often, come out of school where they've learned a lot of the basics of primary care, and then it's hard to break out of some of the habits. So you kind of get in a way of treating a certain thing or working up a certain complaint, and you just kind of fall into that rut and you keep doing it without that many opportunities for learning. So who are we as Penda Health? We're a large digitally enabled primary care practice. So we're based in Nairobi. We have 16 medical centers around the metropolitan area. We have nationwide telemedicine. We've been fully paperless for the last 7 years, and we've done a rule-based clinical decision support within our branches for the last 5 years. And our aim is really to be the most trusted healthcare provider in Africa by creating an outstanding patient experience, of which high quality medical care is obviously very, very important to that. Um, we've had quite a bit of success so far. So we're now one of the largest outpatient healthcare providers in Kenya, treating more than 1,000 patients a day across our network. I want to take us back to the rule-based decision support that we implemented because it's been really key to how we've improved quality. So, like I said, only 40% of healthcare is provided in accordance with national guidelines. And this system has helped us reach 92% at Penda. So, the way it works is when a clinician enters a diagnosis, they get some, local guidelines suggested as options that they can either accept or reject. And so in this case, the clinician is seeing a child with diarrhea and some mild dehydration, and they're getting served those recommendations, which are zinc and ORS. And they can easily kind of accept those and it pops into the medical record. So that system really allowed us to improve how we're matching the treatment to the diagnosis within Penda. That being said, there's gaps because that system doesn't necessarily help us always make the right diagnosis. And so when I first started playing around with ChatGPT when it first came out, like many of you and many people all around the world, it was kind of like very exciting and wow, how can we implement this technology to really improve care? The way the tech at Penda works is really pretty simple. We take rich text-based clinical data, which is essentially, the age of the patient, their gender, their complaint or reason for visit, history, physical examination, lab results, imaging results, basically anything that's in the medical record for that visit. And we append that beneath a highly customized prompt, which is customized not only for our location and our practice setting, but also really to give output in a very particular format that we think is going to be helpful for our clinicians at the point of care. And the result of that is our AI consult output. So we call it AI consult, and clinicians can click a button and then they can get that output automatically within the EMR, within the flow of their workflow. One of the things we've realized is that there's different prompts that are needed depending on the exact clinical circumstances. So on this slide, on the top of the arrow, I have whatever is recorded in the clinical documentation up to that point where you are in the workflow. And then in the bottom, I have different prompt outputs. So you can imagine a patient who is currently in the triage area in a clinic. They're getting their vitals taken by a nurse. They're telling the nurse the reason for their visit. At that point, we could have a prompt that suggests history and physical examination questions for either the nurse or the provider to ask. Once we have history and physical examination documented, we might have a prompt that suggests lab tests or how to fill different gaps that exist in the history or physical. Once we have diagnostic test results, we're now at the point where we want to formulate a diagnosis. So we'd like the prompt to suggest a differential, maybe even to suggest some, red flag diagnoses or sort of, don't miss diagnoses. Once we have a diagnosis that's made, then we may want the prompt to suggest an evidence-based management plan for that patient based on the diagnosis and the rest of the clinical documentation. And really for, all of it, we can also imagine prompts that essentially look at, hey, is everything that's been done here so far, does it kind of check out? Are there any major discrepancies between what's been recorded in the clinical history, the diagnosis, and the treatment? So we've actually already implemented this in our live production environment across all of our clinics. We went live on the 19th of February, 2024. And in the first 3 weeks, that consult button was used more than 2,200 times. And one of the things we noticed is that there was substantial variability at the clinic level. That's something that we've seen in almost all of the different quality improvement implementations that we've done. And I think it's helpful for any technologists or product managers that are in the audience for thinking about how you actually implement a change in a live operational clinical setting, is to really think that, even if it's the same organization or the same technology, different geographic settings and different team cultures will actually like uptake that implementation in different ways. Um, we have this little button that says, was this helpful? And that's for the AI consult advice, basically the result from the prompt, and little, thumbs up, thumbs down. And our clinicians rated the feedback as useful 99.6% of the time. So really positive feedback in terms of, was that advice actually like helpful at the point of care? So that's something I'm really proud of. And one of the big feedbacks that we got from our team was, hey, we want a management plan prompt. which we didn't go live with initially. It was more focused on diagnosis support. And I found that interesting just because, we're coming from having that rule-based clinical decision support. And I think the culture on our team was like, hey, we really appreciate that. And we want those evidence-based guidelines, kind of prompted to us. And so that was one of the big feedbacks that we had. I want to share a success story. I was talking to one of our clinicians, Betty, who told me the story, and she said she was seeing a 30-year-old woman who was in her third trimester of pregnancy and came into the clinic with shortness of breath. And a very kind of routine pattern matching that happens for our clinicians is like shortness of breath, often is pneumonia. It's something that clinicians in Kenya are really trained on because pneumonia is, still a really leading cause of death, particularly in children under 5. And so there's like a lot of attention given to pneumonia and a lot of kind of like, just a clinical habit of treating shortness of breath as pneumonia. And the AI consult suggested, this could be pulmonary edema, maybe caused by preeclampsia or maybe a peripartum cardiomyopathy, and suggested maybe consider referring this patient for further evaluation, which Betty then did. The patient went to a higher level of care, an inpatient hospital, seen by specialists. She was delivered by cesarean section that same day. And we've followed up with them since then, and mom and baby are doing well. So that was like a really cool, very early real world story for how this impacted patient care. And that really leads me to like the first of 3 insights that I want to share with you about what this looks like in implementation. So the first is that large language model clinical decision support can really uniquely support unknown unknowns. So you may have heard of this framework called the Rumsfeld framework, which is dividing what we understand in the clinical space into known knowns. So a great example for our practice setting is like, patient has fever and joint pain and a positive malaria test. Like our clinicians know that they know that the patient has uncomplicated malaria, or a child who comes with a 10-week vaccine appointment, and they know which vaccines are due. There are also known unknowns, and this is what our clinical decision support really tackled. So an example is like, patient has eczema. I'm pretty sure of the diagnosis here, but I just don't quite remember the treatment guideline. So, that's where clinical decision support can work, even a clinician looking up what the treatment guideline is. But of course, we want to use tools that embed that into their workflow to make it even easier and to make it common to do that. So that's an example of a known unknown. I know that I don't know the treatment guideline for this. And so CDSS, our rule-based CDSS, really helped on that side of things. But the unknown unknowns, it didn't really tackle, because if as a clinician you don't know that you don't know something, you don't even know you need to go look it up. Or you don't know to ask for help. And so a great example is the case I just shared. So the pregnant patient has shortness of breath, and I don't know that I should be thinking through other less common causes. Another example is if the vital signs might suggest a greater severity than what the clinician realizes. So an example would be, I'm diagnosing the patient with pneumonia, but in reality, the respiratory rate is high, maybe the oxygen saturation is low, and because the clinician grazed over those numbers, they actually just are not referring the patient or recommending a higher level of oversight on that patient's care. So that's, I think, a really exciting opportunity for LLMs. The second is, I think anyone who's working on implementation needs to be thinking about alert fatigue. So alert fatigue is the concept that, it's a very important concept in health, informatics and implementation, which is that clinicians are really bombarded with alerts. And often those come from very well-meaning implementers and administrators who are trying to improve quality of care. But in the actual workflow, the clinician is just like constantly getting alerts. And when they're too many, what happens is that you start to ignore them. You just, click through, yes, okay, but you don't even read them. And I've been a victim of that myself. And so when we went to implement this, we really wanted to be cognizant of that and thinking about, do we, make this completely optional, which is how we started off our implementation, Do we make this completely forced where we say, hey, you've got to use the AI consult every single time you see a patient? Or do we do something in between? And like I said, we started on the completely optional side because buy-in is so critically important. If I would have, said every time, you're vaccinating a baby, at 10 weeks, you need to use AI consult, we would have a mutiny because that would be just like a terrible clinician, user experience. What we're really aiming to do going forward is to try to find this middle ground where the alerts, do come and the AI consult is used more and more often, but it's used in the most relevant cases. And so a great example of what we'd love to do is to use sort of a background prompt to assess the contextual relevance. And what I mean by that is you can imagine a prompt kind of running in the background that the clinician isn't really seeing happening, that really asks, is there a serious mismatch between what's been documented clinically, the diagnosis, and the treatment plan? And when the large language model sort of detects that, hey, yes, there is this, something serious might be missed here, then it can kind of trigger the clinician to use the AI consult and then really understand what they're missing and then act on that. Other concepts that we're exploring are like user related set points. So maybe you have like, a new clinical staff who's like right out of school. You might want to kind of push more AI consult utilization for that type of user as compared to someone who has like a lot more experience, and has like great kind of clinical outcomes already. Um, and I think in any case, one thing that's really key is that close partnership with clinicians. We really need to be building these tools like right alongside the frontline clinical staff. The last insight that I want to share with you is just I think comprehensive clinical documentation is going to become the new quality KPI. And I love to use this example, especially for non-clinicians who want to understand, like, how helpful is this tool? And so you can imagine asking ChatGPT to write a letter of recommendation. And in the first example, I'm just saying, write me a letter of recommendation for John. And it does an okay job, but the output is kind of boring and not really inspiring. Whereas if I give it a prompt that has quite a lot of detail and context about John, this is a friend and colleague, I've worked with them for 5 years. Here are his strengths and weaknesses. Here's an anecdote from when we worked together. Now the output that we get from that is really quite strong. And the same thing is true for clinical documentation. So we need to feed really rich clinical data. From the whole spectrum of care. That's, history and physical, as well as lab results. Vital signs are obviously like vitally important, and imaging results and all sorts of things to really get the best output from these tools. um, One of the interesting things is that you don't even need necessarily clinical expertise for this to work. So if I hear someone say there's a golf ball size swelling behind the knee, I know that that's a Baker's cyst. But even if, let's say, a nurse doesn't know that that's like the medical term for what that is, if they just document there's a golf ball size swelling behind the knee, an LLM also knows what that is, right? And similarly for very specific phrases, even that the patient may use, like, I feel like someone's hammering a nail into my temple. An expert clinician, that might immediately trigger a thought of cluster headaches. If the frontline staff, it doesn't automatically trigger that for it, it will still trigger that for the large language model. So to me, it kind of gets at, we'd really like to create a scenario where we have very high fidelity transfer of whatever is actually happening with the patient into text inside whatever the electronic health record is, so that the large language model can act on this in the best way possible. So I want to end just by talking about what's next. For Penda specifically, we are looking to do a really detailed peer-reviewed evaluation of quality, and there's sort of two stages to this. The first is looking directly at the AI output and really saying, okay, like, this one was great. What made it great? This one was not so great. Maybe it wasn't sufficiently like locally relevant, or maybe it just, didn't actually serve up what we think are the true differential diagnoses for this situation. The second level is looking at what actually happens with real world patient outcomes. And that's an even kind of broader research endeavor. But I think it's really important that we're seeing ultimately what is the outcome for patients when these tools are put into place. The second thing we want to do is use retrieval augmented generation for really kind of fine tune the localization of the output. And that's both for the types of, disease burden that we see here, but it's also for things like what is Penda's unique, formulary, and what lab and imaging tests are available to us. The last thing is we want to keep building trust with users. Ultimately, like, one of my mentors said that healthcare moves at the speed of trust. And that's true not only for patients, but also for clinical staff. So our clinicians really need to trust these tools, and we need to do that through this kind of like, slower and process where we really walk together as we build these tools. In terms of the ecosystem, one thing that's really exciting about the Kenyan ecosystem is there's already quite a number of examples of leapfrogging with technology. So probably the most famous one is that, Kenya never really developed like an extensive system of landline phones. We just jumped straight to, 90 plus percent penetration of mobile phones. And I think the same thing is going to happen with some of these quality improvement efforts in healthcare. So I think we may see many of the clinics that are still paper based really kind of bypassing, okay, basic digital clinics, bypassing rule based decision support and going straight to this like much more advanced and nuanced and ultimately, hopefully, helpful generative AI based decision support. So I think that's like a really exciting thing about working, in low and middle income countries and working, on a problem that I think is really quite urgent and needs a lot of support. So I want to just do a special thank you to some of our key partners. The Ministry of Health Kenya has been really closely involved in this work and helping us develop this safely and ethically and in accordance with the law. The Patrick J. McGovern Foundation funded our implementation of this project, and Enterprise for Development has been really instrumental in our quality improvement efforts. So thanks to our partners. And I want to end just by saying, like, if anyone wants to, help us work on this, like, I'd be really eager to hear your feedback and to connect even outside of this. So, thank you so much for listening and your attention. I'm really happy to engage with you on questions.